Alright, hello, good morning. I've decided to make some videos of the lectures that we missed from the snow day on February 2nd. So this lecture is going to be for chapters 21, 22, and 23, drugs for hypertension, lipids, angina, MI, and CVA. That's a little joke that you can read later. So there are many different factors that affect the blood pressure, three of them being blood volume, peripheral resistance, and cardiac output. So blood volume, if there's more fluid on board, then that's going to increase the blood pressure. If there's fluid loss, then that's going to decrease the blood pressure. Fluid retention is related to the hormones aldosterone and ADH. ADH means antidiuretic hormone. Peripheral resistance is affected, and the diameter of the arterioles is affected by the SNS, the sympathetic nervous system, and also something called the renin-angiotensin II system, and also with blood viscosity. If the blood is thicker, then it's going to cause an increase in blood pressure. Cardiac output is directly related to stroke volume and heart rate, which we'll talk about a little bit later. There is a equation, cardiac output equals stroke volume times heart rate. Stroke volume is affected by things such as preload, contractility, and afterload, which we will get into the definitions, kind of a review if you forget what those are. And the heart rate is directly related to the sympathetic nervous system, the parasympathetic nervous system, and epinephrine. So this is the homeostasis of blood pressure. So the body is always trying to keep blood pressure within normal levels. So if there is a high blood pressure going on, then the compensatory mechanism of the cardiovascular system kicks in, and also the kidneys kick in to counteract this high blood pressure. So in terms of the cardiovascular system, what is going to happen with the vessels is that they're going to dilate. Also, the stroke volume is going to decrease, the heart rate is going to decrease, which affects the cardiac output, because cardiac output equals stroke volume times heart rate. With the kidneys are going to release more urine, which will decrease blood volume. All of these factors will decrease the blood pressure back to normal, hopefully. So this is the equation that I've been talking about. Cardiac output equals heart rate times stroke volume. Stroke volume is affected by preload, afterload, and contractility. So let's review what these terms actually mean. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. Stroke volume is the amount of blood ejected by the ventricle with each heartbeat. Preload is the volume of blood in the ventricles at the end of diastole, right before the next contraction. Contractility is the force of contraction of the myocardial fibers, and afterload is the peripheral resistance against which the left ventricle must pump out to the rest of the body. This is a kind of complicated diagram for me. I'm not sure if you like it. I'm not going to go through each step here, but basically these are the hormonal and nervous factors that influence blood pressure. So hypertension, the diagnosis is rarely made on a single blood pressure measurement. This is because the blood pressure changes frequently throughout the day. If you have a coffee or you exercise, your blood pressure will increase. If you take a nap and lie down for a while, the blood pressure decreases. But once we get a few readings in the office, so sometimes it's up to 6 different readings that the blood pressure is continuously high. Stage 1 hypertension is diagnosed when there's a systolic blood pressure from above 140 to 159, and a diastolic blood pressure of 90 to 99. With that being said, there's a great emphasis on lifestyle modification. If someone is diagnosed with hypertension, pills will not just take care of it. The person also has to change their lifestyle, which includes some of these things. So increasing physical activity, lowering the salt consumption. With that being said, you always have to remember when we're looking at these medications, what is going on with salt. So a really good thing to remember is that wherever sodium goes, water goes. So for example, if you've eaten a lot of chips that have a lot of salt on them, the next morning usually you feel bloated because you've consumed a lot of sodium, and wherever salt goes, water goes. So it causes you to be a little bit bloated, you're keeping more fluid on board. So that's an important factor when we're teaching about salt in the diet, and also that comes into play when we're talking about sodium in the body and how it affects blood pressure. A balanced diet is important, decreasing the consumption of alcohol, stopping smoking. Smoking directly affects the vasoconstriction of the arteries and vessels, so that will increase blood pressure, and maintaining a healthy weight or losing weight. So the first drug class I want to talk about for treating hypertension is diuretics. The other classes are calcium channel blockers, angiotensin converting enzyme inhibitors, or ACE-I is kind of the short form we use, angiotensin 2 receptor blockers, ARBs, adrenergic agents, which includes beta blockers, and direct-acting vasodilators. This is a chart that I like to use when I am prescribing a medication, antihypertensive medication for a client. So basically what's going to happen, you have that target, the person is over, their blood pressure is 140 over 90 or a little bit higher. You always educate about lifestyle modification. Lifestyle modification is always in combination with pharmacotherapy. And then your first line agents are a thiazide diuretic, an ACE inhibitor, an ARB, long-acting calcium channel blocker, or a beta blocker. Now when we look at beta blocker, we can see that it says it is not indicated as first-line therapy for people over the age of 60. Can you think of a reason why it would not be first-line for someone who's a little bit older, over 60? Well, the reason is actually because as a person ages, their beta adrenergic receptors kind of lose their potency, I guess you can say. They don't work as well. So if we give a person a beta blocker to decrease their blood pressure, it might not work as good because their receptors aren't working as well as they used to when they were younger. And then we can see when we go down here, there's dual combination therapy or triple or quadruple therapy. So oftentimes one drug class isn't enough to lower blood pressure. People are usually on 2 different drug classes, 3 or even 4 different drug classes to try to control their blood pressure. With that being said, if someone is diagnosed with hypertension, the majority of their time there's no cure for it. So they need to have this lifestyle modification. That might be enough to lower the blood pressure, but most often they also need a medication to lower the blood pressure. So they will take their blood pressure medicine and it's going to control the blood pressure for them. And then sometimes people will stop taking their medicine because they feel like it's been cured. My blood pressure is not high anymore, so I stopped taking my medicine. But basically, there's no cure for hypertension most of the time. So that's called essential or primary hypertension. If someone has secondary hypertension, which is listed over here, that means that there's something causing the hypertension. For example, if someone has a tumor on their kidney, which is causing them to keep fluid on board, that will increase their blood pressure. So if we go in and remove that tumor or remove that kidney, then that should cure the problem of hypertension. So they wouldn't need to be on these medications long term. All right, again, a pretty complicated diagram. I don't really like these. If you do, that's great. But I'm going to talk about each drug class. And so basically this is just showing you that these drug classes are affecting different areas of the heart and the brain and the blood vessels. All right, diuretics. These are a great drug class for hypertension. They are used first line because they're very safe. And so basically what they're doing is they're causing diuresis. They're causing the client to urinate a lot. So it's going to decrease blood volume through increased urinary excretion of water and electrolytes. And sometimes it's used alone, so you could start with this one. If it's not working to decrease the blood pressure where we want it to be, then they're usually combined with other medications. And because we know that people don't want to take a lot of medications every single day, oftentimes the drug companies will make it as a combination pill. So a diuretic along with, maybe a calcium channel blocker together to decrease the blood pressure, so they only have to take maybe 1 pill a day. These are the diuretics for hypertension. As you will see, there's a drug subclass called potassium sparing type, and then the thiazide and thiazide-like agents, and then loop diuretics. The main thing I want you to take from this is that diuretics, they all increase diuresis, but some will keep potassium on board, will keep potassium within the body, and some will lose potassium. So you need to know the difference between the two of those, because that's going to directly affect how you educate your client of what they should eat and what they should stay away from in terms of potassium. So potassium sparing means that they will keep potassium in the body. So they should be cautious as to how much potassium they are consuming. So we definitely wouldn't want them to take a potassium supplement. If someone is taking a thiazide diuretic, then these clients are losing potassium through their urine. So then we would want to educate them to increase the potassium in their diet, and they might very well be on a potassium supplement. The one that we are going to talk about is the prototype drug, hydrochlorothiazide, which is a very common diuretic that you will see. So it works by decreasing the reabsorption of sodium. So we have these terms, reabsorption and absorption. Reabsorption means that the body is bringing it back into the body. Okay, so with the reabsorption, if we're going to decrease the reabsorption of sodium, again, sodium and water go together. Wherever sodium goes, water goes. So if we're kind of blocking the sodium from coming back into the body, the sodium is being released into the urine, and so is some water. So then there's going to be decreased fluid in the body. And this is great to treat mild and moderate hypertension and also with heart failure, which I will get into with some other videos. Adverse effect of all of antihypertensive medications is always hypotension. So then if you look in your drug guide, you might see side effects like dizziness, fatigue, weakness. They are all probably related to hypotension. Another big thing with diuretics is dehydration. The client is losing lots of fluid and electrolytes, so we're going to be cautious with dehydration. With that being said, with the electrolytes, the most important one, or one of the main important ones, is potassium. So I have a question for you. With a thiazide, again, it's right in the name with hydrochlorothiazide. With a thiazide diuretic, are these clients losing potassium, or are they keeping potassium on board? And then, depending on that answer, would this lend them to have hyper or hypokalemia? So with a thiazide diuretic, they're losing potassium, so they are more at increase of hypokalemia. Another note to know is that you have to be cautious when the person is taking digoxin. Digoxin I'm going to be talking about in my video about heart failure. Alright, so moving on to calcium channel blockers. What's going on here is a calcium. We're blocking the calcium ions that are going to be going into the blood vessels, or blocking the calcium ions into the heart, which affects if the blood vessel constricts or dilates, and if the heart is going to have a big forceful contraction or not. So by blocking that, it's going to relax arterioles, increasing the vasodilation. It's going to lower peripheral resistance and lower blood pressure. And with the heart, it's going to decrease contractility of that heart muscle. So it's used to treat angina, dysrhythmias, and of course hypertension, because that's what we're talking about. So these are some drugs that are listed as calcium channel blockers. And as you can see from the stem, or the ending of the name, we can get a clue when we look at the generic name to what drug class it belongs to. So amlodipine, so pine, P-I-N-E, is one of the endings that you'll see with calcium channel blockers. Diltiazem. So Zem is another, Z-E-M is another ending that you'll see with calcium channel blockers. And then verapamil, M-I-L, or mil, is one of the endings that you'll see. So one of the things that you could remember is that You can take them pines to the mill. Take them pines to the mill. So them pines to the mill is one way that you can remember the endings for calcium channel blockers. So the prototype drug we're going to talk about is nifedipine or Adalat. The mechanism of action is that it blocks calcium channels in myocardial and vascular smooth muscle. So again, it decreases cardiac contractility and it causes vasodilation to decrease the blood pressure. So it's used with hypertension and angina. The side effects, again, number one, hypotension. It can cause headaches, dizziness, flushing, heart failure, and that's kind of related to the cardiac contractility and also edema. So this is the one where grapefruit juice comes into play. So if someone is taking in grapefruit juice with their calcium channel blocker, what it does is it increases the absorption of the calcium channel blocker from the GI tract. So there's more drug on board. So it causes greater than expected effects from the dose. And it can be even worse if someone takes grapefruit juice with a suspended release calcium channel blocker. So this could result in a rapid toxic overdose, which is absolutely a medical emergency. So role of the nurse. What you want to do with any hypertensive medication is to take their blood pressure before. Another one with calcium channel blockers, you want to take their heart rate also. So to get into a good habit of all antihypertensive and cardiac medications is to take their heart rate and blood pressure before you administer the medication. You have to be careful if someone is sitting at a heart rate of 60 or below, of course, before you give any kind of antihypertensive, specifically with calcium channel blockers and beta blockers. Obtaining a blood pressure in the lying, sitting, and standing positions. Do you know what this is called? What kind of procedure are we doing to obtain these readings? So this is referring to orthostatic hypotension. So when the person goes from a lying, especially from a lying position to a standing position, the body should regulate the blood pressure. But if it's not, when they go from a lying position to standing, their blood pressure will really drop, and that is called orthostatic hypotension. We want to assign for signs and symptoms of heart failure because that's one of the risks and side effects that can occur with a calcium channel blocker. So peripheral edema, shortness of breath, lung congestion, and I'll talk more about heart failure in an upcoming video. Obtaining daily weights. This is in relation to that heart failure piece because if someone gains weight day to day, it is most likely water weight. So if they're retaining a lot of fluid, they're going to gain weight quickly. And if someone is gaining weight from day to day, it's less likely to be from fat loss or fat gain. All right, so the RAAS system is another kind of drug class that we're going to talk about. So the renin, angiotensin, aldosterone system, that's where the RAAS comes from. Aldosterone is missing from there. So this is what happens under normal conditions. So it's a key homeostatic mechanism that controls blood pressure and fluid balance. So under normal conditions, if the body senses that the blood pressure has dropped, so there's low blood pressure, or sodium levels are decreased. So again, wherever salt goes, water goes. So if there's not a lot of sodium on board, then there's not going to be a lot of water on board. So the first thing that happens is that the kidneys excrete renin. Renin converts angiotensinogen to angiotensin 1. And then angiotensin 1 passes through the lungs and it's converted to angiotensin 2. The problem with angiotensin 2 is that it is one of the most potent vasoconstrictors known. So that's how it increases the blood pressure under normal conditions. But if we have someone with a high blood pressure already, then why don't we take care of that, blocking that effect of angiotensin 2? So the enzyme that's responsible for the final steps in converting angiotensin 1 to angiotensin 2 is called the angiotensin converting enzyme, ACE, ACE, angiotensin converting enzyme, and that's where our ACE inhibitors come from. So this intense vasoconstriction of arterioles caused by angiotensin 2 increases blood pressure by increasing peripheral resistance. Angiotensin 2 also stimulates the release of aldosterone, an antidiuretic hormone, which both increase fluid on board, thus increasing blood pressure. So this is a diagram of what I just explained. So the liver is constantly producing angiotensinogen. When the body has a low blood pressure, the kidneys react by secreting renin. What renin does is it converts angiotensinogen to angiotensin 1. Then we need this angiotensin converting enzyme to help convert angiotensin 1 to angiotensin 2. So this is a step. This angiotensin 2 is such a potent vasoconstrictor, so it causes vasoconstriction of the arterioles. The flip side of it is that it also promotes aldosterone to be secreted from the kidneys, which increases sodium reabsorption, increasing the blood pressure. So what we want to do is we want to take care of this angiotensin converting enzyme, or we want to block the effects of angiotensin 2 with the medications that we're going to give. So ACE inhibitors and ARBs are both drugs that affect this RAAS system. So they're going to decrease blood pressure by blocking vasoconstriction and also increase in urinary output. And some of the drugs in these classes also decrease heart rate. So they're very similar because they're in the same drug class, but again, they're a little bit different, of course. So ACE inhibitors, they stop the production of angiotensin 2, and ARBs, they block the action of angiotensin 2. So here is the list from your textbook again, and so we can see ACE inhibitors, they all end in pril, P-R-I-L. So captopril, enalapril, lisinopril. So when we see that ending of pril, we know that it's an ACE inhibitor. For ARBs, they all end in sartan, cansartan, losartan, irbesartan. So if we see that sartan ending, we know that it's an ARB. So drugs affecting the RAS. ACE inhibitors, the prototype drug we want to talk about is enalapril or Vasotec. It reduces angiotensin 2 and aldosterone levels. Again, so the primary use is hypertension. Main effect is hypotension. Also this dry, naggy cough, which I'll talk about. Hyperkalemia. So hyperkalemia, we always worry about the heart and any kind of dysrhythmias that can occur with either hypo or hyperkalemia. Hyponatremia, because what these medications do is that they increase diuresis. So wherever salt goes, water goes. So hyponatremia is a side effect. And also something called angioedema, which is an allergic reaction. So this is a picture of one type of angioedema. So it's causing the tongue to be very large. And this is a very common side effect actually of ACE inhibitors. I've seen it happen quite a few times. So usually it occurs when the person is first starting the ACE inhibitor, so the first few days or first week or so, but it can actually occur at any time. It can occur if they've been on an ACE inhibitor for months or years. So oftentimes people will come to the emergency room with this because what do you think is happening with that big tongue there? It's blocking his trachea, it's blocking his airway. So what is this here in his nose? They stuck in his nose. So that is a nasal airway. So he is getting his air through his nasal passage, but they're just making sure that that nasal passage stays open, so they've put in an airway. All right, so a dry cough. Oh man, ACE inhibitors, they do tend to cause this really nagging, annoying dry cough. So they can both cause it, ACE inhibitors and ARBs, but ACE inhibitors tend to cause this dry cough more often. So sometimes if the ACE inhibitor or ARB is working well for the client, it's really reducing their blood pressure nicely, or they have contraindications to any of the other drug classes, then, they might decide that they want to stay on this medication. So some of the things that they could do is to use 2 or 3 pillows at night to help with the cough. But again, if your client is saying, ever since I started this medication, I have this cough, they might not know about this side effect. So it might be beneficial that you try, or the prescriber switches them to a different drug class just to get rid of this annoying symptom. All right, adrenergic agents. This is probably kind of the hardest drug class to understand because we're talking about the autonomic nervous system again, just like we did when we talked about pulmonary medications. So the basic idea is that we're blocking the effects of the sympathetic nervous system to decrease the blood pressure. So the side effects are generally predictable extensions of the fight or flight response. Some are selective for the heart, so those would be the best, but some are non-selective. Non-selective means that not only the heart is affected, but the lungs are affected and the blood vessels are affected. And if we remember back to the pulmonary unit, if we block the SNS, then within the lungs, it causes the bronchi to constrict. So that can be a problem with someone with asthma or COPD. We always want to dilate the bronchi for them, and that's why we have adrenergic agonists when we're talking about bronchodilators. But if we block the sympathetic nervous system, this can be a possible side effect that we want to be careful with. And also with regards to blood vessels, it causes vasoconstriction. So there are 4 different categories of adrenergic agonists. There's alpha 1, alpha 2, beta 1, and beta 2. So we'll talk about alpha first, but we're going to mainly focus our studying and our thinking on beta blockers because that's what you hear a lot about and that's what you're going to see the most. But we need to just go through alpha 1. So alpha 1 antagonists, okay, so this is important. Most of them block 3 of the 4 categories block, but alpha 1, so alpha 1 antagonizes, but alpha 2 actually is an agonist, so it promotes it. So alpha 1 antagonists, they cause vasodilation. It's used commonly for BPH and urinary obstruction. So benign prostatic hypertrophy, if someone or if a man has a large prostate that's constricting the urethra, then these medications will help them to urinate better. So alpha 2 agonists, they actually act directly on the brain to reduce the blood pressure. So they're really not considered first line because they have a lot of side effects, namely sedation and depression. What we are going to talk a lot about are beta blockers. So beta 1, the primary locations are in the heart and the kidneys, so that's a really good one to choose. Beta 2 blockers are located in all sympathetic target organs except the heart, so it's kind of an indirect effect on the heart. And beta adrenergic blockers, so they're either cardioselective, which are beta 1s, or non-specific, and they include beta 1 and beta 2 receptor blockers. So when we look at our list from our book, we can see that with beta blockers, atenolol is a beta 1 blocker, so that's a great one because it's affecting basically the heart only. Bisoprolol, again, is a beta 1 blocker. Metoprolol is a beta 1 blocker. Things like propranolol and timolol, they're a beta 1 and beta 2 blocker. So then we might have effects like bronchoconstriction and vasodilation that we might want to be careful with and watch out for. Then you have your alpha 1 blockers, alpha 2 adrenergic agonists that act on the brain, and then some other categories that we don't have to focus too much attention on. But what I really want to focus on is the beta blockers. So the prototype drug is metoprolol, so low pressor. Mechanism of action is that it's selective to the beta 1 antagonist and reduces myocardial oxygen demand. So the treatment, its primary use is a treatment of hypertension, angina, and MI. Adverse effects, the main one is hypotension again, bradycardia. So with the beta blocker, they do also decrease the heart rate. So we have to be careful that we take their blood pressure and heart rate before we give a beta blocker. Now, a caution is that patients with a history of asthma should not take due to possible bronchoconstriction effect. But what I just said was that beta blockers are specific to the heart. Beta 2 blockers are ones that can affect the lungs and the arteries and vessels. But the thing with metoprolol is that at low doses, it's selective to the heart. But when you get into higher doses, it could affect the lungs, which causes bronchoconstriction. So again, with any kind of beta blocker, whether it's only a beta 1 receptor blocker or a beta 1 and beta 2, we still have to be careful that it could possibly still cause problems with the lungs. So with people with pulmonary disease, we have to be careful. The other drug class I want to talk about is direct-acting vasodilators. So just like the name says, what it's going to do, it's going to directly relax arterial smooth muscle to decrease the blood pressure. The problem with these medications is that sometimes they can reduce the blood pressure too quickly. If someone is sitting at a high blood pressure for a long time, the body gets used to it. And if we go in and we decrease that blood pressure dramatically and instantaneously, then there can be a lot of side effects. We never want to decrease blood pressure too fast. And one of the examples, prototype drug, is hydralazine. So hydralazine, it's again causes vasodilation. It's used for hypertension. Here we see it again. An adverse effect is hypotension. The reflex tachycardia comes into play when we've decreased that blood pressure too quick, too fast, and the body's reacting by increasing the heart rate to deal with that. There's something called the lupus-like syndrome and sodium and fluid retention that can occur with these direct vasodilators. Okay, so this is a list of the medications, the specific medications that I might test you on in test number 2: hydrochlorothiazide, Adalat, Vasotec, and Lopressor. So these are just 4 of some of the drug classes I talked about, and as always, you're responsible for knowing what the different drug classes cause. So I'd like to go through that chart that I posted on Blackboard so that you know that you have the right answers going on here. So for diuretics, so all of them are going to decrease blood pressure, but for diuretics, the main mechanism of action is that it's going to increase urine output. No real effects on heart rate, cardiac contractility, or vasodilation. For calcium channel blockers, some will decrease the heart rate, and most or some will decrease the cardiac contractility, which comes into play when we talk about heart failure. But the main thing that they do is that they cause vasodilation. Urine output, actually some may decrease urine output because they tend to cause edema. Beta blockers are similar, have similar side effect profile to calcium channel blockers. So some, actually a lot, will decrease the heart rate, so we have to be careful with heart rate and beta blockers. They will decrease the cardiac contractility. Some will increase vasodilation, and there's no real direct effect on the urine output. ACE inhibitors and ARBs are in the same drug class, so they're going to have similar effects, similar side effects. They're just a touch different. So some will decrease heart rate, no real effect on the cardiac contractility. They both increase vasodilation, and they both increase urinary output. Direct vasodilators, again, they decrease blood pressure, no real effect on heart rate or cardiac contractility, but they do, like in the name, they increase vasodilation and no real direct effect on urinary output. All right, so I hope that helped you. I'm going to move on to make some more videos for you with lipids and the other units that we missed. Okay, thank you.